Mr. Chairman. I will present our experience with laparoscopic gastric banding. It's a personal experience. There's nothing to disclose. It's a single surgeon's experience and the duration of the material from 2012 to 2017. The Global Burden of Disease study, which was published in the Lancet Medical Journal, stated that 2.1 billion overweight and obese individuals in the world, 3.4 million deaths in 2010 attributed to excess body weight. There are more than 50% of women in Kuwait are obese. 38.5 in 1979, went up to 45.6 in 2016. As you can see, Kuwait is one of the countries with the highest incidence of obesity and overweight. Obesity rates are increasing from 13.4 in 1962 to 36.4 in 2014. Bariatric surgery is the only successful and durable long-term treatment for obesity, putting in mind the chronicity of the disease. Short history about bariatric surgery in Kuwait. In 1997, vertical banded gastroplasty have started. 1999, gastric banding and intragastric balloon have been introduced. 2003, Roux-en-Y gastric bypass. 2005, sleeve gastrectomy. 2010, duodenal switch. 2014, 15, single anastomosis gastric bypass and some cases of SADI. 2017, the endoluminal gastroplasty. Actually, the aim of this or our review is just to see if gastric banding is good to do. Shall we continue doing gastric banding? How to improve our results? Our sample material, we have 315 patients, most of them with the Swedish adjustable gastric banding. The mean weight was 99, mean BMI of 35.6, and the mean age of 31. Looking at the 2 years follow-up with the average BMI drop, we can clearly see that there is a continuous drop of the BMI from the day of surgery, going to a maximum weight loss in the 18 months and goes a little bit higher, 24 months, again until 3 years, the curve goes a little bit higher up. The average BMI difference, that's actually the same information, but it's put in a different graph. We tried to see if there is any difference between subgroups, if we have patients with a BMI 35 and below, and those patients with a BMI of above 35. And actually, the two curves are almost similar and identical at 24 months. We can see at 3 years, the curve continues to the group with a lower BMI 35 and lower, and it goes higher up at the group of BMI above 35. When we are looking at the excess weight loss, again, there is a continuous, excess weight loss for a period of 2 years. We can see a gradual increase in the percentage of average excess weight loss, and the maximum reached in 18 months, it's around a little bit above 45%. Then it drops down at 3 years, and the curves actually continues, not dropping significantly almost till 3 years. And we can see that the rate of the average excess weight loss is around 40%. Now this curve is hypothetical curve because this is the original curve, the one we saw with the 3 years follow-up. Sorry, this. So this is our original curve at 3 years for the percentage of excess body weight loss. Then we just remove the patients who have removed the band in the future, and we just want to see if this will affect the result or not. And then we get a better curve. Sorry, that's very sensitive. So if we remove the patient who have removed their band after 3 years, actually the excess weight loss gets a little bit higher than 45%. Again, in the subgroup, there is not a statistical significance at the weight loss. It is actually a p-value of 0.07. It's not considered statistically significant, and this is the group with a lower BMI, and this is the group of a BMI above 35. Now, we were looking for factors which might affect the excess weight loss. And if we plot the excess weight loss with the follow-up counts, which means how many times the patient has come to the outpatient, it's very clear that the more the patient comes for a follow-up, they have a better weight loss and a percentage of excess weight loss. And that is actually statistically significant. We can look at it in this curve much better. And this means the average excess weight loss for the minimum BMI achieved by the patient. And we can see clearly. So actually, this is statistically significant in all the follow-up visit, except between the 4th and the 5th visit. There is no statistical significance. Otherwise, any 2 points between each other, it is statistically significant. And it really shows the importance of the follow-up for patients, especially with the gastric banding. We had no mortality, band removal 29 cases. We have 2 slippage, 2 band migration. However, this might not be accurate. We are trying to call all our patients, but some patients we cannot really get in touch with them. And some patients have removed the band perhaps in another hospital. But this is all the information we get. Even if the patient didn't come to our clinic, we are trying to call them and get the information. Looking at the literature, Paul O'Brien and John Dixon have shown actually in a study for almost 6 years follow-up after gastric banding, lab band outcome results, they have a persistent excess weight loss above 50%, and they have stated that lab band placement is proving to be safe and effective. It should be considered the optimal initial approach for control of obesity and its comorbidities. Dr. Luigi from Italy, he has showed a nice study, a comparison between gastric bypass and gastric banding, and definitely gastric bypass, they have a better weight loss than gastric banding. But actually, if you look at the starting BMI of 45 with the gastric banding, and in 5 years they reached to 35, I think that's quite significant amount of weight loss if you are able to lose 10 points on the BMI scale. There is a long-term result after laparoscopic adjustable gastric banding for morbid obesity, 18 years follow-up. In a single university unit, obesity surgery was written by Arabis and published 2017, and they have said despite good initial results, late complication, weight regain, and intolerance led to band removal in nearly half of the patients over time. However, given that there is no good information on alternative procedure in the long term, and considering its reversibility and safety, it still has a place in the treatment of morbid obesity for informed and motivated patient. Again, Dr. O'Brien, in their review of the literature, weight loss and early and late complication, the international experience, they have stated that the lab band proving to be extremely safe, able to facilitate good weight loss and able to maintain weight loss over time. And the range of the excess weight loss was between 52 to 65%. We could really simply conclude that laparoscopic gastric banding is a safe reversible procedure. It has a 0 mortality. It can maintain excess weight loss of 40% over 3 years. Frequent visits to the clinic is associated with a better excess weight loss. Better selection of patients with adequate patient education can lead to a better excess weight loss and the maintenance of excess weight loss. Laparoscopic gastric banding can be used as an initial procedure for weight loss, especially for patients not accepting laparoscopic sleeve or Roux-en-Y gastric bypass, because we have a sector of patients in Kuwait, they are really afraid to do laparoscopic sleeve or laparoscopic gastric bypass. Also, according to the ministry criteria, if your BMI is below 35 and you don't have a metabolic syndrome, then you are not allowed to do gastric bypass or sleeve. So those patients, sometimes they'll look for alternative procedure, which could be the gastric bypass. Actually, I visited Dr. O'Brien in Australia, and I have seen his patients going to his clinic with this weight, and they are going out of his clinic like this weight, and we are really looking forward to adopt the Australian model to improve our results in the gastric bypass and the gastric band. Dr. Abaid, fi time? I have just 2 short videos. Yeah. This is usually we start dissecting at the angle of his, just to make a space for the band to pass through. And almost all our patients have been done with the pulse flaccida technique, dissecting through the pulse flaccida. Putting the gold finger, retrieving the band. Usually we don't remove the band of fat which you see between the, unless there is a big vein or something really obstructing the passage of the band. And then we put a couple of stitches, gastrogastric stitches, to keep the band in position. And the second video, تعال أبو حسين. لحظة شوي بس خلنا نربط هذه على الأقل. Okay, that's how it's done. Okay, تقدر تسكره. وشغل لنا الثاني اللي مكتوب عليه باند ريموفل. باند ريموفل هذا فوق. ايه. So this is one of the difficult cases with band removal, because once you go in you don't see the band. Sometimes you see the band and sometimes you don't see. And the idea is to go dissecting and burning over the band and over the tube, and then it gets a bit easier if you do that. It might take some time. You have to be a bit meticulous. This patient actually removed the band just because, I mean, he is heavy from his weight loss and he doesn't want the band anymore. So there was no slippage, there was no erosion. It was just a simple band removal. And usually when we do a simple band removal, not always we open the rab, as far as the patient is not willing to do a second procedure at the same time. Okay, I think it's the band cutting and then band removal. Thank you very much for your attention. Thank you.
Thank you, Dr. Khalid. Next speaker will be